Welcome to our video on disorders of the pancreas. Let's get started. Here's an overview of what we'll be discussing in this video. We'll go through diabetes mellitus, obesity, metabolic syndrome, and various pancreatic neuroendocrine tumors. Let's start with diabetes mellitus. Diabetes mellitus is a clinical syndrome characterized by hyperglycemia resulting from defective insulin secretion, decreased insulin action, or both. The two most common types are type 1 and type 2. Type 1 diabetes is characterized by absolute insulin deficiency, which results from autoimmune destruction of the insulin-producing cells of the pancreas. On the other hand, type 2 diabetes is characterized by peripheral insulin resistance and an inadequate compensatory response by the islet cells, those cells of the pancreas that produce insulin. So it's a relative insulin deficiency. We'll discuss more about these two types on our next slide. Other important types of diabetes are gestational diabetes, caused by increased insulin resistance during pregnancy, and secondary diabetes, in which hyperglycemia is caused by an underlying medical condition or drugs. And we'll discuss those more in a few minutes. Lastly, diabetes can also be caused by genetic defects in insulin secretion. For example, maturity onset diabetes of the young, or MODY. Here's a table which compares and contrasts between type 1 and type 2 diabetes. Recall from step 1 that type 1 diabetes is caused by T-cell mediated progressive autoimmune destruction of the insulin-producing beta cells of the pancreas, eventually resulting in an absolute insulin deficiency. On the other hand, the key pathogenic factor in the development of type 2 diabetes is peripheral insulin resistance, together with an inadequate compensatory response by the pancreatic beta cells. So there's resistance, and the pancreas just can't keep up with it. Now, since some insulin production is retained, it's actually called a relative insulin deficiency, like we mentioned before. Now, both of these types have complex multifactorial etiologies, including both environmental and genetic factors. For example, certain viral infections are thought to trigger the onset of type 1 diabetes, while the important environmental factors related to type 2 diabetes are overeating, sedentary lifestyle, and obesity. Now, genetic predisposition is high in both of these diseases, but diabetes type 2 has a much stronger genetic component than type 1. Coming to the associated conditions, type 1 diabetes is frequently associated with other autoimmune disorders, such as celiac disease, Addison's disease, thyroid disease, and vitiligo. And that can actually be a helpful clue on exam questions. Most type 2 diabetics are obese, and they actually have other predisposing environmental factors that we talked about, such as sedentary lifestyle and overeating. Now, many patients also have metabolic syndrome, which is why they have other metabolic disturbances, such as dyslipidemia and hypertension, in addition to this abnormal glucose metabolism. Now, we'll discuss metabolic syndrome a bit more in detail later. Now, type 1 diabetes mostly occurs before age 40, typically during adolescence. In contrast, type 2 diabetes usually occurs after age 40. However, the prevalence has actually been increasing in the younger population. Now, ketoacidosis is very commonly seen in type 1 diabetes because of the absolute insulin deficiency, but it's very rarely seen in type 2 diabetes because, as mentioned earlier, these patients retain some capacity to make insulin, so they manage to keep ketogenesis in check. Now, refer to our lecture on acute complications in diabetes mellitus for a more detailed review of that concept. Secondary diabetes is when diabetes occurs secondary to another identifiable underlying disorder or even drugs. For example, diseases causing pancreatic destruction, such as chronic pancreatitis, cystic fibrosis, and even hemochromatosis can cause diabetes if the islet cells of the pancreas are destroyed. Additionally, recall from step 1 that various hormones such as cortisol, thyroxine, and growth hormone have opposing actions to insulin. They favor hyperglycemia, and therefore they're called counter-regulatory hormones. Now, increased levels of these hormones may occur in disease processes such as acromegaly, Cushing syndrome, hyperthyroidism, or in patients taking steroids. And they can cause hyperglycemia severe enough to actually cause diabetes mellitus. Now, other medications such as thiazide diuretics can also cause secondary diabetes. Glucagon is another counter-regulatory hormone that favors hyperglycemia, by opposing the actions of insulin, and therefore glucagonoma can actually cause diabetes mellitus. So in other words, if you have a disease process that counteracts insulin, forcing the pancreas to work super hard and produce more insulin, then you're going to eventually get diabetes. So what are the primary metabolic disturbances seen in diabetes mellitus? Well, insulin is a major anabolic hormone, and therefore its deficiency results in a catabolic state. So all the energy stores are actually broken down. Insulin deficiency promotes increased glycogenolysis and increased gluconeogenesis. This, together with reduced peripheral glucose uptake, leads to hyperglycemia. Additionally, insulin deficiency results in increased lipolysis, which consequently increases the blood-free fatty acid level, and also leads to increased ketogenesis in the liver. The glycerol released from the breakdown of lipids is used as a substrate for gluconeogenesis, and that actually just further exacerbates the hyperglycemia. There's also increased proteolysis in low insulin states, again providing substrates for gluconeogenesis, leading to increased hyperglycemia. These metabolic derangements, such as hyperglycemia and increased lipolysis and proteolysis, are responsible for the classic symptoms of diabetes mellitus. And these are polyuria, polydipsia, and polyphagia. Now, polyuria occurs because the glucose that enters the nephron doesn't get reabsorbed because it's overwhelming all of the glucose transporters. Once that happens, glucose just starts spilling into the filtrate and gets urinated out. And all that glucose in the urine has osmotic power and pulls water into the urine. So it forces the patient to urinate more. So this is osmotic diuresis. And because there's glucose in the urine, it's glucosuria. As a result of this polyuria, the patient actually tries to drink more to increase their water intake because they're dehydrated. Also, because they're losing so much fluid, there's an increased osmolarity of their serum. So that actually triggers their thirst reflex. And since insulin isn't actually driving glucose into the cells, the patient starts to develop hunger. They're like, basically the cells are starving from glucose from decreased glucose utilization. And of course, they're burning through other stores through proteolysis and lipolysis. So in other words, they're going to eat more. And all of this loss of energy reserves in the form of proteolysis and lipolysis means the patient will lose weight. So let's discuss the clinical presentation of both types of diabetes. So type 1 diabetes, as mentioned earlier, occurs in people aged less than 40, and it typically occurs in adolescence, and it has the classic hyperglycemic symptoms such as polyuria, polydipsia, polyphagia, and weight loss. However, many patients with type 1 diabetes first present with a condition known as diabetic ketoacidosis. It's an acute state of severe insulin deficiency, which leads to severe diuresis. And volume depletion and unrestricted keto acid synthesis leads to severe acidosis. And please refer to our lecture on acute complications in diabetes for a more detailed discussion on diabetic ketoacidosis. Now let's go to type 2 diabetes. This is usually diagnosed after age 40, but as mentioned previously, the incidence is actually rising in the younger population. Now, since these patients retain the capacity to make some insulin, the classic symptoms of hyperglycemia are less common. So they'll actually be asymptomatic and perhaps undiagnosed for many years. In fact, they are often diagnosed incidentally during workup for chronic fatigue and other comorbidities such as hypertension and dyslipidemia. Now, the complications of diabetes can be divided into acute and chronic complications. Now, the two most important acute complications are diabetic ketoacidosis associated with type 1 and hyperosmolar hyperglycemic state associated with type 2. Chronic complications include various macrovascular and microvascular complications such as myocardial infarction, stroke, and diabetic nephropathy. Now, all of those complications are discussed in our lectures on acute complications and chronic complications, respectively. How does insulin deficiency lead to some of the classic symptoms of diabetes? So when there's an insulin deficiency, glucose cannot enter cells, leading to relative starvation. And this promotes the breakdown of glycogen and gluconeogenesis. The results of the glycogenolysis and the gluconeogenesis, along with the poor uptake, results in a hyperglycemic state. The hyperglycemia of the blood leads to increased filtration and excretion in the kidneys, which results in polyuria and glucosuria. Now let's discuss the diagnostic criteria of diabetes mellitus. The confirmation requires any one of these tests to be positive, and they have to be positive on 2 separate occasions. These include a fasting plasma glucose of 126 or more, or a random plasma glucose of 200 or more, and it has to be in a patient with typical symptoms of diabetes, so those symptoms of hyperglycemia, or following a 2-hour oral glucose tolerance test, they have a level of 200 or more. Now, all of these tests can be repeated the next day for confirmation, except the HbA1c level, which actually has to be repeated 3 months later. This is because hemoglobin A1c is formed by irreversible glycation of hemoglobin A, and therefore it's stable over the red blood cell's lifespan, which is 120 days or 3 months. So you have to wait for those to cycle through. As already mentioned, hemoglobin A1c measures glucose control over the last 3 months, and it's actually the best test to monitor long-term glucose control in diabetic patients. The oral glucose tolerance test is the most sensitive test of all, and it's therefore the diagnostic test of choice for screening in pregnancy and PCOS. Other labs ordered in a patient with diabetes are urea and electrolytes, creatinine, liver and thyroid function tests, so LFTs and TFTs, a lipid profile, and urinalysis. Now, these tests help assess the severity of diabetes and the presence of complications and other related comorbidities. So, they're not actually helping you diagnose diabetes, they're helping you diagnose its complications. Now, if signs and symptoms of a patient with diabetes suggest an underlying medical disorder, workup for secondary causes will be indicated in order to diagnose it. And this is important because treatment of the underlying disorder can actually cure the diabetes if there's not already irreversible damage done. So how do we manage a patient with diabetes? The most important part of treatment is glycemic control. So you want to shoot for a hemoglobin A1c level of 7% or less, and you want their fasting blood glucose level to be 130 or less, and their peak in postprandial glucose to be 180 or less. Now, by postprandial, we're referring to approximately 2 hours after they eat. In addition to ensuring good glycemic control, we have to put specific attention to all of the possible complications that may occur in a diabetic patient. So you're actually anticipating and managing and trying to prevent complications as a routine part of your glycemic control and treating your diabetic patient. This includes treating other metabolic disorders such as hypertension and dyslipidemia, as well as regular screenings and management of the vascular complications of diabetes. In this lecture, we'll focus mostly on how to achieve strict glycemic control. Now, this is a very high-yield concept. Strict glycemic control has different effects on macro and microvascular complications. For example, it's been shown to significantly reduce the risk of microvascular complications in both types of diabetes. And these microvascular complications we're thinking of are diabetic retinopathy, nephropathy, and neuropathy. Now, it's also been shown to reduce the risk of macular vascular complications in type 1 diabetes specifically. However, the effect on the macrovascular complications of type 2 diabetes isn't all that certain. And since most death in diabetes patients occurs due to macrovascular diseases such as myocardial infarction, the effect of glycemic control over the all-cause mortality is also uncertain. Now, by uncertain, we mean that it has not shown significant benefit in the prevention of these complications. Additionally, a number of studies have shown that an aggressive reduction of hemoglobin A1c to less than 6.5% may even be detrimental to the cardiovascular health of these patients, and it's actually associated with increased cardiovascular mortality. And this is particularly the case with elderly type 2 diabetes patients, especially where they have multiple other cardiovascular risk factors. That's why hemoglobin A1c is mostly kept around 7% in most patients. There are a number of interventions that can help a patient achieve and maintain near normal glycemia. These include lifestyle modifications and pharmacologic interventions. As you know already, type 1 diabetes is characterized by an absolute insulin deficiency. So, these patients invariably require insulin therapy. If they're not making insulin, you've got to give it to them. So, as soon as you diagnose type 1 diabetes, you start giving insulin therapy. However, mild type 2 diabetes can sometimes be managed with lifestyle modifications alone. And so the usual protocol is that all type 2 diabetes patients are first advised to achieve glycemic control by lifestyle modifications, which we'll talk more about on the next slide. And if that fails, they're prescribed a single oral hypoglycemic agent. Now, metformin monotherapy is the usual first-line medication in most patients. However, it all really depends on which oral hypoglycemic agent will be of the most benefit to an individual patient. And other agents may be used as first line with regard to that individual's risk factor profile and comorbid conditions. So regardless of what you choose, you're going to start with an oral hypoglycemic agent. And if that single drug doesn't work, the next step is to try 2 drugs from 2 different classes. And again, the choice of drug still depends on the individual patient's risk factor profile and their comorbidities. But simply put, you're just increasing from 1 to 2. And at last, if both drugs, 2 at once from 2 different classes, doesn't work, then you need to give them insulin. In fact, most type 2 diabetes patients eventually require insulin therapy. Let's briefly discuss the recommended lifestyle modifications. So this is mostly applicable for type 2 diabetics. Most patients will be required to avoid saturated fats and added sugars in their diet. So basically, you just got to eat healthy. We all intuitively know that you shouldn't eat saturated fats and lots of sugars. So in these patients especially, you're making sure they don't do that. Now, exercising is a very important intervention. It's actually supported by the fact that physically inactive people are more likely to develop insulin resistance when compared to physically active people from the same level of obesity. So even if they have the same amount of excess fat on their bodies, the actual activity of moving around can help reduce their insulin resistance. The usual recommendation is 30 to 60 minutes of moderate intensity exercise at least 5 times a week. Also, weight loss is strongly encouraged in obese patients, and smoking cessation for those who smoke. Again, fairly intuitive things to do in patients who even aren't diabetic, and that's especially important in diabetics. Lose weight, quit smoking. And all these interventions help maintain glycemic control as well as reduce long-term cardiovascular complications. Here's a table showing all the classes of hypoglycemic agents. This is mostly step 1 pharmacology, and our focus of attention will actually be this column of notes, which discusses the additional benefits and side effects of each drug. Now, knowing these additional effects helps us choose a hypoglycemic agent based on an individual patient's comorbid conditions or other such factors. So let's begin with metformin. This promotes weight loss, and it's preferred when, in addition to glycemic control, you want the patient to lose weight. So metformin is helpful. However, since metformin is renally excreted, its use is contraindicated in conditions with reduced renal blood flow or reduced renal function. For example, patients with renal failure, hepatic failure, or cardiac failure. Now, giving metformin in patients with reduced renal function actually increases their risk of lactic acidosis, and that's a life-threatening complication. It's actually really rare in patients with normal renal function. Sulfonylureas and meglitinides increase insulin secretion, so they have a similar side effect to insulin therapy itself. That is, they can actually cause hypoglycemia and they can cause weight gain. And this is because insulin lowers blood glucose level and promotes the synthesis and buildup of energy reserves. So weight gain naturally ensues. Thiazolidinediones, or TZDs, are associated with weight gain and fluid retention. So if the patient has heart failure, that increased fluid retention can exacerbate their heart failure. Now, I want to pause for a moment before discussing the rest of these drugs and help remind you that we have a pharmacology chapter full of image mnemonics that cover all of these. So if you have a hard time memorizing these or remembering the mechanism, please go see that. In fact, all of the videos on each of these drugs in that chapter are actually really short, so it's worth your time to go memorize those. Now, glucagon-like peptide analogs cause weight loss and are also cardioprotective, and would therefore be preferred in cases where cardiovascular risk reduction or weight loss is required. Although dipeptidyl peptidase 4 inhibitors, or DPP4 inhibitors, have a similar mechanism of action as GLP-1 analogs, they actually don't have any effect on the weight of the patient. So DTP4 inhibitors are considered weight neutral. Sodium-dependent glucose cotransporter inhibitors, or SGLT2 inhibitors, also have additional benefits, such as weight loss, and they also reduce the progression of diabetic nephropathy, and they reduce cardiovascular mortality. Now, by inhibiting this sodium glucose transporter, these drugs actually cause increased sodium delivery to the macula densa of the distal convoluted tubules. And this results in reduced activation of the renin-angiotensin-aldosterone system via tubuloglomerular feedback, thereby reducing intraglomerular pressures and reducing the progression of diabetic nephropathy. Alpha-glucosidase inhibitors inhibit dietary glucose absorption and will understandably cause osmotic diarrhea and bloating. In addition, decreasing the glucose that's absorbed from the intestines can actually cause hypoglycemia. Now, pramlintide can also cause hypoglycemia, and it does this by delaying gastric emptying. So they delay the glucose delivery to the intestines for absorption. Insulin therapy is an essential part of therapy in all type 1 diabetics, at least eventually in type 2 diabetics. And insulin can actually be used alone or in combination with other hypoglycemic drugs. So what are the side effects of insulin therapy? Well, they're fairly intuitive. They can cause hypoglycemia, which makes sense because they actually take the glucose that's in the serum and puts them into the cells. So serum glucose level will drop. And because of that insulin activity, then glucose-releasing processes, such as gluconeogenesis and glycogenolysis, will actually be inhibited. And insulin is anabolic overall, so they're going to start increasing lipogenesis and glycogen synthesis, which leads to weight gain. Now, subcutaneous administration is the most common method of administration, at least used in long-term outpatient management. And the common sites of injection are the buttocks, the thighs, and the abdomen. Now, in contrast, intravenous insulin, such as regular insulin, is used in emergency situations because you need rapid action. So you want them to get into the bloodstream quickly and then do their activities in the blood. So, for example, if a patient has diabetic ketoacidosis or hyperosmolar hyperglycemic state, then you want to put it into their veins. And we talk more about DKA and HHS in the acute complications of diabetes lecture. Glycemic control is to be monitored on a regular basis in all diabetic patients. And to monitor long-term glycemic control, we check hemoglobin A1C every 3 months. Additionally, daily monitoring of blood glucose is to be done by every patient at home using a capillary glucometer. And this is particularly important for those taking insulin or sulfonylureas. And that's because there's risk of hypoglycemia with these agents. So, optimal timing and dosing of these agents is crucial. Now, generally, patients on insulin are recommended to check their blood glucose before meals and at bedtime because you want to guide appropriate dosing. And the best guide is checking your current blood glucose. Now, patients should also be encouraged to check their blood glucose 90 to 120 minutes after meals to monitor for any postprandial hyperglycemia. And this is because patients may have poor overall glycemic control simply due to this postprandial hyperglycemia, even if they have good control of their blood glucose during those times in between meals. So this postprandial period is very important. Now let's talk about the dawn phenomenon and the MODY effect. Dawn phenomenon is morning hyperglycemia due to nocturnal secretion of growth hormone, which is a counter-regulatory hormone that opposes the action of insulin. Now, you can actually counteract this by increasing the evening insulin dose and actually help prevent that morning hyperglycemia. In contrast, the MODY effect is morning hyperglycemia, which is actually a rebound response to nocturnal hypoglycemia. Now, when a patient has hypoglycemia, even nocturnal hypoglycemia, then there will be increased secretion of counter-regulatory stress hormones, such as cortisol and epinephrine, that are released in an attempt to increase blood glucose level. What they end up causing is a rebound elevation of blood glucose. So when the patient wakes up, they have hyperglycemia. So ironically, you actually treat the MODY phenomenon or the MODY effect by reducing the evening insulin dose because you're trying to prevent that nocturnal hypoglycemia. So a 53-year-old female with a BMI of 45 and liver cirrhosis secondary to alcohol use has a fasting glucose of 163. The patient is already taking a high-intensity statin for hyperlipidemia. What is one of the hypoglycemic agents this patient should be started on and why? So this patient has multiple historical variables that will contribute to choosing the diabetic therapy. For example, there's liver cirrhosis. The patient is at high risk for cardiovascular events because of the hyperlipidemia and a BMI of 45. And on top of all that, she has diabetes. With all that in mind, a sodium-dependent glucose cotransporter inhibitor, or SGLT2 inhibitor, would actually be a good option for this patient. In addition to glycemic control, this may actually help the patient lose weight and also reduce cardiovascular mortality. Now, you might be thinking about metformin, which is generally a first-line treatment, and it promotes weight loss. So there's 2 reasons why you should use metformin in this patient. But you're actually worried about kidney function because of the liver cirrhosis. And remember, with decreased kidney function, you're worried about lactic acidosis, which is why you want to avoid metformin. So, probably the best hypoglycemic agent to choose in this patient is an SGLT2 inhibitor. And that concludes this section.